Thank you for tuning into our best practice series for medical providers working with refugee and immigrant youth and families. This is one video in a larger series hosted by the Trauma and Community Resilience Center at Boston Children's Hospital. Each short video will highlight experts in the fields of medicine and psychology who work with refugee and immigrant youth and families. We are grateful to SAMHSA and the National Child Traumatic Stress Network for their support in making this series happen. In this video, we will be hearing from Dr. Anahí Venzor Strader. Anahí is a pediatrician from Chihuahua, Mexico. She is a recent master's graduate from Harvard Medical School and practices as an acute care pediatrician at Winchester Hospital and Boston Children's Hospital. She is an associate researcher at Maya Health Alliance in Guatemala, where she leads a project to improve newborn survival. Her main areas of research and practice are the health of Indigenous children, migration, and social medicine. As an immigrant herself, she has been involved in initiatives to support the health of immigrant children and families since her residency in North Carolina. Since coming to Boston Children's, she has acted as the clinical lead for the clinical pathway for newly arrived immigrant patients, which provides support and guidance for primary care providers caring for children after migrating to the United States. And now it is my pleasure to turn it over to Dr. Venzor Strader.
Thank you very much, Alyssa and Amy and the whole team for having me here. And thank you for watching this video. I am going to attempt to give a small talk about immigrant child health, particularly for the primary care setting. I know this is a huge talk, so apologize that I'm not going to be able to go into detail into a lot of the topics that we're going to talk here, but we're going to try and keep it to short but important clinical pearls. And I'm really hoping that this can be helpful in your practice. The outline, we're going to talk about a bit about migration history and why is it important for us as primary care physicians, little about legal jargon, social screening, infectious condition screening, biomedical, and other screenings that are important, as well as preventative services. So we know that there's a lot of factors that push families to migrate or to leave their country of origin. If you can see it in this graph, the gray majority of these factors are actually outside of their social immediate circle, and they include economic drivers and environmental, geopolitical constraints, etc. And so this can be a very sensitive subject for the child and the family. Every time that you are asking about migration history and the details, make sure that you are sensitive about it and that you explain how it ultimately relates to the child's health and why you care for it. What is important to you? What were the places that they needed to stay and for how long? Was there any exposure to trauma, both psychological and physical? Do they bring records with them? Did they go through any medical screening before, especially immunization records? These are all going to be important things. And make sure that this might not happen in the first meeting. So you might need to, ask in the second or third meeting if there needs to be some trust building first. A little bit about immigration statuses. This is not an exhaustive list, but just so that we can have some common terminology. Refugee or asylees are people who left their country of origin or where they left because of fear or experience of persecution or violence. And they have already been granted status. Refugees usually come through the refugee settlement agency to a refugee settlement agency, and they get plugged in with an agency that helps them through assimilation and settling into the States. Asylum seekers are people who have placed an application to become asylees, but this has not been yet processed or not been accepted. It is legal to come to the US border to ask for asylum. That is constitutional. A lot of people who are asylum seekers might be within the United States or might actually be outside of the United States. They do not have formal benefits, and they might not have work permit or other documents. So it is very important for us to know that. Again, they might be already in the United States, or they might be waiting outside, or part of their family might be waiting outside while their application is in there. Undocumented is a very, very broad term for people who basically have no legal status in this country. They might overstayed their tourist visa or their student visa, or they might have come through other means like with the migrant caravan, etc. Um, there are like legal permanent residents, which already have a green card, and so they are deemed as green card holders, and they do have much more benefits and than other statuses, and have access to more services as well, but not all as a U.S. Citizen, but they have a clear pathway to citizenship, at least most of the time. There are also temporary visas, right? Student visas, work visas, tourist visas, etc. Which I'm not going to get into the weeds of right now. Something important to note for your clinical practice is avoid documenting the status of either the patient or their caregivers in your clinical notes in case they, for some reason, end up being accessed by entities that we wouldn't want. We wouldn't want that information to be public on. And we can always disclose that if we are talking about documentation status, it's only because it relates directly to the child's health as well, insurance and in other ways. But it will be absolutely confidential information. There's a very big important part of our work as primary care physician is our social screening for social determinants of health. So in it's going to be extremely important to talk about the family and social network that the patient already has in the country or might not have and needs to build, right? And maybe we are the first social network that they encounter. And so just to have that in our mind and to take the responsibility for that. Obviously, we will talk about school, how much school they completed outside, how long have they been out of school for, are there any services that are needed, or maybe screenings that are needed to do for any neurodiversity issues or learning problems, right? Making sure that we address those. And have they access school? Do they know that they can access school regardless of their documentation status, right? That's very important. Um, in terms of trauma, what was their exposure to trauma? What are the symptoms that they are showing? I'm sure that there are more talks in this series that talks in more detail about this, but us as clinicians, what are the symptoms that are presenting in this patient, and how are they related maybe to the history of trauma that this patient might have endured? Um, what is the housing situation? Where is the family living? How many are they living in there? How are they dealing with what are the resources that they know are they are entitled to, and have they been able to access them, etc. And then insurance status, which obviously relates a lot to the previous slide where we're talking about documentation status. I know it's a lot of things, and we might not be able to deal with everything in this one 30-minute visit. I am aware of that, but just something that we want to have a list of things and a checklist in our minds. In terms of infectious screenings, it obviously going to depend a lot on where patients have been and how their exposures have been shaped, right? So that's why we want to know the type of where patients have spent some time and where did they stay, so that we know kind of according to the epidemiology of different places, we know what to screen or presumptively treat for. According to evidence-based recommendations, all children 13 years and younger, should be screened for HIV unless their mother status can be documented and there are no like significant risk factors, right? Like previous sexual encounters or any history of sexual trauma or, abuse in any way. And obviously every patient 13 and older might be screened even if their um, mother status has been documented. Always think about tuberculosis, especially if in an area with high endemicity, which is recognized as probably anything outside of Western Europe, Australia, New Zealand, Canada, maybe places like Japan as well can count there. But think about tuberculosis. Anyone now, the Red Book recommends IGRA or T-spot or quantiferin gold, which is an immune assay for all patients, including infants. It is an acceptable test and it's much easier than the TST or than the skin test. And it's much accessible and it is an acceptable screening solution. Hepatitis B is important and should be done with the hepatitis B surface antigen. That is our appropriate screen. Think about strongyloides, getting an IgG for strongyloides, and if it is positive, presumptive treatment should be done with ivermectin, except for patients who are from lower endemic countries. Um, think about treatment or presumptive treatment or screening for malaria in patients, particularly from sub-Saharan Africa, or you can check the world malaria map for areas that are 30 or 40% or more prevalence of malaria. You should be thinking about a parasite blood smear for screening or treat presumptively with coartem, which is easy enough as well, depending on the access to medicine. Schistosomiasis, also think for that for patients from sub-Saharan Africa, and the treatment or the lab that should be done is an IgG as well. Other parasite important screenings are Chagas disease or Trypanosoma cruzi for patients from Latin America, um, especially continental Latin America. So Mexico, Central America, and South America. The Caribbean islands do not have as much prevalence of this, but you can order also an immunoassay for Trypanosoma cruzi. And it is really important because it can cause long-term complication and is a truly, truly neglected disease. So think about it for our Latin American immigrants. Also, STI screening if there are special risk factors, especially like 15 and older or any history of previous sexual encounters. Other thing it is not in our list, but it's very important, is the intestinal screening. So you can get ova and parasite stool samples, two different ones separated by 24 hours, or treat presumptively with albendazole, with one single dose of albendazole. In terms of biomedical screening, so what is outside infections that can also affect the health of our patients? One of them is newborn screen for patients under 6 months and younger. I live in Massachusetts, and right now we can send for up to 6 months. We can still send the newborn screen. So it might depend on where you live, but find out, and then patients might hugely benefit from this. Other screens that are basic at birth and we sometimes give for granted are hemoglobin electrophoresis to find out about any hemoglobinopathies that can also affect their lives and their growth. G6PD deficiency, you can do a qualitative or a quantitative study depending on what's available in your system. Think about lead for everyone 16 and younger. And actually, there is literature to say that you should consider repeating lead even 3 to 6 months after the patient has been living in the United States, because there is so frequently immigrant patients do not have appropriate housing and might be exposed to lead after coming to the US. So consider repeating the level for lead. And lead poisoning is still very, very prevalent, as you know, can affect their can strongly affect their development and their growth. And we only think about usually under 1 or 2 years old. But in the immigrant population, it is recommended for everyone 16 and younger. It is really hard to be a primary care provider to do this primary care initial visit, right? There's so many things to think about. If you think yourself as this doctor here, there's just so many things in your mind that do not fit in a space of 30 minutes. So it would be really, really important for you to set priorities and set treaties kind of with families, acuerdos, that you will know what is most important to the family to address in this specific meeting, right? You might have all these priorities in your mind because that's what medical school taught you, but parents might have different priorities, and I think that the balance between those two will be really important first step for building trust. Then you will ask yourself, what is was the most important for me as a doctor that is non-negotiable? Like this is, I'm really worried about this, that I really need to address this first. Then other things maybe we can deal with in 2 weeks or in 3 weeks. And so set that expectation that there might be follow-up appointments, and it doesn't necessarily mean that there is something wrong, but that we want to take everything step by step and that we can be that support to families. Maybe it is a lot of pricks for that patient in one day in terms of lab and immunizations, etc. So what things can I delay? Or maybe the mom says, you know what, for me, it is better that we just take, excuse me, so that we just take care of everything in this one visit so that I don't have to come back. So it has to be something that is worked out together with you and the family. But also set reasonable goals, right, for your visit. I cannot deal. Oh, we didn't even talk about dental screening, for example, and how important it is for them to know that they should access a dentist and that they should schedule that appointment, right? So, but maybe that's not a priority for the family, so that's okay. It might take a couple months, etc. Building trust and setting priorities. In terms of preventative services, I know we did not address the issue of immunizations. In general, what I have found to be um, most common in the literature is that if there are no records of vaccines, just go ahead and revaccinate according to the CDC catch-up schedule. Except for the varicella, that might be the only one that is worth checking the antibody profile, particularly an IgG, just to see, especially if the mom or the caregiver says that they did have exposure to varicella, that they did have the varicella infection, so that they can go ahead and you can go ahead and confirm that the patient is immune for that, and you don't need to revaccinate. For all of the other ones, you just go ahead and revaccinate according to the CDC catch-up schedule. Um, we didn't get to go in detail about growth and nutrition, but really important to look at height, weight, and the percentiles for these patients. Remember, the diagnosis of acute malnutrition is done through the C-score of what weight for height and not weight for age particularly. Which is another type of malnutrition. So it's something that we don't, I think, routinely look at. So pull up those WHO growth charts so that we can refer appropriately if there are any concerns for malnutrition. But if not, then it's important to start the conversation about counseling for good nutrition, for appropriate nutrition. And think about also signs of micronutrient deficiencies. We are going to get as well a CBC with differential. I think it is very important, and I'm sorry that I didn't add it in my list, but I think adding a CBC with differential to check for hemoglobin and also to check for eosinophilia for to because if we have eosinophilia, then it might be even more relevant to check for parasites, the different parasites that we talked about in the infectious screen. So just something to think about, and always get that hemoglobin, that CBC with the differential, so that we can identify eosinophilia. And then just discuss the need for preventative visits, right? Make sure remember that the routine well child checks that we are so accustomed to here in the US might not be routine in every country. And so the caregivers might not be familiar as with that concept of bringing the child to the doctor when they're not sick or repeatedly in like a period of 3 months. So just set that expectation and say like we might want to see them just for vaccines or just for, developmental checks. And that doesn't mean that there's anything wrong with them or that it's just kind of routine practice to identify things prior to when they happen. Okay. In terms of resources that you can access, there are many, but I just chose two, which are my favorite. One of them is the Immigrant Health Toolkit from the American Academy of Pediatrics. We will provide links in the show note in the video notes which you can get a lot more detailed information about every screen that we talked about here. And then Doctors for Immigrants just has a lot of amazing resources about just sometimes even addressing issues when it comes with legal concerns or just a lot of educational stuff for us doctors about how we can better welcome families that are coming from other places and we can grow our community that way. Thank you so much. That will be all for me today.
Thank you. If you can switch to the next slide. Thank you so much, Dr. Venzor Strader, for sharing your expertise with us today. It was absolutely delightful. And we thank all of you for watching. If you are interested in learning more, visit our YouTube channel for more videos. The link is in the video description. Thank you again.